My name is Nancy Gray, and I am the Assistant Director of Health Information Management at Paxton St. Luke's Healthcare. When a patient arrives to the hospital, a record is created, and the staff here every day go and pick up records, whether the patient was in the emergency room only or if they were an inpatient. They may have also been seen on the endoscopy units, and they go to those units and make sure that they've collected all the records from the day prior, and they bring them downstairs, and then they start the process. Those records as soon as they come downstairs. When they come downstairs, some records would go into file folders, and all records sometimes are maintained in different formats. And once they come downstairs, the record has to be assembled in the proper order. Make sure all the documentation is present in the record. That should be depending on the patient type. Then the record is analyzed to make sure that all the deficiencies, the physician's signatures are all present. And the discharge summary, if it's required, is asked and requested by our department to make sure it gets completed. And then it goes to the coding area, where the record is then reviewed for documentation, and we read the record and assign diagnostic codes and procedure codes for what the type of care and the problems that the patient arrived with. Okay, we have some of the coders have a 2-year degree, which is their RHIT, and then we have those that have a 4-year degree, which is RHIA, and I also have some coders who have their CCS, which is a certificate program. All of them have taken national exam, and they have to pass the exam in order to work in their current function right now. Coding is when the coders review a record and they read all of the documentation that's present in the record. They assign diagnosis and procedure codes, which are numbers which match up to the problem a patient presents with and their final diagnosis, or the things that the patient is being cared for, medications they're on that relate to a condition, and any procedures that they may have had performed. They use ICD-9 coding books, which help them through this process. They also use different software that helps them as well. And when a coder has a question for a physician, they write a query to the physician to get his final say. Coding has to be based on the documentation within the record. If the documentation is not in the record, then we cannot code that condition. And this is important because if a physician leaves out an important element, it could mean a difference in dollars to the hospital and reimbursement. So if a patient comes into the hospital and they have a diagnosis of pneumonia, and the doctor never documents that the patient also had an ulcer, perhaps on their foot or anywhere, we could be losing a lot of money. So it's very important for the doctor to document all the conditions that the patient has, and even history of conditions that the patient may have had. Maybe the patient in the past has had a TIA or a CVA, and that could impact the patient's care as well. You know, if a patient is blind, that could impact their care. That would mean it may require more nursing services to help to take care of that patient. If a patient can't see where they're going, now you have to be able to justify the increase in cost to take care of that patient.
Sure.
So we have to make sure that we can get proper reimbursement to care for that patient. There's different types of coding. I have inpatient coders, and I have outpatient coders, and I also have coders who work in the clinics that are associated with the hospital, and ones who specialize in ER coding and urgent care as well. So there's many levels of coding that someone could come in depending upon their educational or their area of expertise. There's also, not only use ICD-9 coding, but they also use what they call CPT coding as well. And that is just for procedure codes. The documentation drives what codes that we choose. And we also have coding guidelines that we have to follow, which are determined by the American Hospital Association, have written policies and procedures that we have to follow so that we're coding ethically. We can't code something that's not there and not well documented, because that would be fraudulent. So we are totally driven based on the documentation within the record. Sometimes when you're reading a record, you may have one physician that states one thing, and you may have a consulting physician that may document something totally opposite. In those instances, we have to go back to the physician and query the attending physician on what he feels was wrong with the patient. He is the one who has the final say as to what we can code. And if there's ever any question in our mind, we have to ask the question. We have to ask the questions. And also, if there's a condition that in the coding book we are able to specify further, then we go back to the physician and ask him for his assistance. We can't make those decisions on our own. On a record that is holding up an account and we can't drop the bill, if we have a question on a chart that we cannot drop that bill because it's going to have a change, it's going to change the reimbursement that the hospital is going to receive, that record is placed on hold, and we wait until we get a response back from the physicians. And we have a great rapport here with the physicians. Many times we can call their office, or they'll stop down the same day that we're coding the record and help us out. And then we have other physicians that will come in over the weekend and answer our queries for us. And we keep close tabs on those records to make sure that they get out on a timely basis. We also have other quality measures are also put in place too. We are reviewed by insurance companies, by Medicare, Blue Cross, all of your insurance companies do come in, they do audit our records, and if there's any discrepancies and they don't feel that our coding was justified, they do come in and write us a letter, and the coders respond to those insurance denials, and they have to be able to show the documentation. Sometimes they have to require them to go back to the physician, and the physician will help to substantiate the diagnosis for us as well. And they have to use their coding knowledge, the coding rules and regulations to back up why they coded something a particular way to protect the reimbursement that we've just asked for. The medical record, after we're done coding it and it's been billed and the physician has completed all of his work, then all of the charts are maintained in our permanent files, and we purge the records on a yearly basis, and they are stored and could be stored in different mediums. Some of them may be sent to Iron Mountain for storage purposes so we can retrieve them at any time. They also may be put on microfilm. And that's where it's going to be a great thing when we get to electronic medical record, because we're going to try and get away from the paper format and get into the world of electronics. And that'll be a wonderful thing for everyone, because then the record will be available to whoever needs it at any given time. As a point of service for a patient coming into the ED, it would be available for the staff right away.